One of the reasons why I think a lot of people have sort of misgivings about CBTI and think it's kind of like a terrible treatment, it won't work for them, is because the clinicians who provide it aren't really, in some ways, thinking about CBTI in a nuanced perspective and tailoring the treatment to really make sure that we're meeting the patients where we're at. And one of the most egregious examples I can think about is somebody who just says, hey, like, I see that you're, sleeping 6 hours, so I'm going to give you 6 hours time in bed, and here's your sleep restriction. So just do the thing and your sleep will get better. And unsurprisingly, this is going to be an extremely painful experience for the patient, especially if they're not, helped to understand why they're engaging in this behavior in the first place, and given the proper structure and support to be able to manage the other factors like anxiety to actually help them reap the benefits of engaging in sleep restriction in the first place. Otherwise, they're just going to go do it, be able to have a terrible experience, and then be like, you know what, CBTI sucks and I'm never going to do it again. Hi, if you're new here, my name is Dr. Parky. I'm a clinical psychologist and behavioral sleep specialist, and in this video, I'm going to talk about an interesting topic called case formulation. Like, how do we understand what is maintaining, or how do I think about patients when I'm thinking about what is maintaining their specific sleep problems, and how I provide the specific strategies needed to make sure they're actually getting what they need in order to break out of their insomnia cycle. So when I'm working with patients with insomnia, this is my perspective. Typically, people with insomnia have started to change their sleep habits or the way that they think about their sleep that is maintaining their sleep problem in the long run. That there's no more external obvious stressor. It's not because they're having trouble sleeping because they're having an exam or something. It's just they have this sleep problem that's being maintained by certain cognitions and certain behaviors. And these cognitions and behaviors impact one of three main systems. One, it impacts our ability to build up sufficient pressure for sleep or appetite for sleep. So compensatory behaviors like spending more time in bed, trying to take a nap during the day, reducing activities, or things that impact our circadian rhythm. So this is stuff like, sleeping in or having variable schedules, sleeping in on the weekends or going to bed early because they're thinking, I need to get more sleep, so I need to go to bed early, as well as things that impact our fight or flight response or hyperarousal. So this could be things like, being really, really anxious about their sleep. They're worrying all the time at night, or they sort of condition their bed to be associated with wake instead of sleep. So all of these behaviors and thoughts are kind of working together to maintain the sleep problem. And my job as a sleep clinician is to figure out which of these three factors are being most influenced and how can I pick the right strategy for them so that they can take it, use it, and break out of the insomnia trap. So this formulation, that is what is maintaining a person's sleep problems, is going to be unique from person to person. For some people, their main issue might be casting a wide net because they found that they have a lot of difficulty falling and staying asleep. They started spending more and more and more time in bed, which again makes sense, but is actually maintaining their sleep problems by keeping their sleep light and their, a lot of awakenings in the middle of the night. So one of the strategies that can be really helpful would be time in bed restriction, where we bring how much time that person is spending in bed a little bit closer to how much sleep they're actually producing. Or another person who goes to bed and notices their mind starts racing might benefit from something like stimulus control, where they start only going to bed when they're sleepy and they get out of bed if sleep is not coming, or engaging in like worry time if they notice their worries are primarily related to, work rather than sleep, or if it's more sleep anxious thoughts, then it might be helpful to engage in more cognitive therapy and kind of dealing with some of those anxious thoughts. So you can kind of see how one strategy might work really well for one patient, but be really actually ineffective for another patient, and in some cases can actually be damaging, like what we talked about with sleep restriction in the context of someone significantly anxious who hasn't had sort of the treatment or the therapist to be able to help them with the anxiety before they engage in sleep restriction therapy. So if you are to become your own insomnia therapist in a way and treat your sleep problems, you need to sort of understand what are certain behaviors or ways I'm thinking about my sleep that could be contributing to a low sleep drive. So maybe again, spending too much time in bed, or conditioned hyperarousal where the bed has become associated with the sort of wakefulness, or maybe it's something else. So you need to be thoughtful as to, is it affecting my sleep drive? Is it affecting my circadian rhythm? And is it affecting my sort of anxiety about sleep and hyperarousal, in order to pick kind of the right strategy for you? And if you're interested in learning more, I've written a book. It's called The Insomnia Paradox, which talks about how you can become your own insomnia therapist and teaches you all the skills necessary to kind of deal with your specific sleep problem. And of course, I also have dozens of videos on this channel that talks all about kind of evidence-based treatments of chronic insomnia. So feel free to check them out if you're interested. Otherwise, I'll see you in the next one. Bye-bye.